All right. What's the next question?
So fourth question says, hi Dave, thanks for the great videos and information. I'm a 51-year-old male in good shape, but would like to be excellent. Right on. As well as optimize vitality and longevity. I run 3 times per week and do dumbbells and body weight exercises 3 times per week, but I'm lacking the zip I used to have, and the belly fat is becoming more and more difficult to keep off. I currently take 50 milligrams of DHEA orally. Recently tested numbers. Looks like T total is 440 nanograms per deciliter. Bioavailable T looks like 1.43 nanograms per deciliter. Free T 7.6 nanograms per deciliter. That doesn't sound right. SHBG 50 nanomoles per milliliter. Excuse me. TSH 1.8. Anyway, general questions. Could HCG be beneficial to reasonably optimize these numbers? And he puts in parentheses, in lieu of replacement therapy and to maintain testicular function. Can HCG be used safely long term? And then, have you seen any clinical benefit from daily DHEA only? Thanks, Kai. Okay, so at 51 years old, these numbers are not unusual, first of all. And you say, okay, well, again, that's why I like his beginning. As I say, it's normal to get sick and die one day. So just because these are normal doesn't mean they're necessarily good or optimal.
Yes.
And again, you don't treat numbers, so I should back up and say, again, drawing attention to he doesn't feel like he used to feel, and he's having trouble despite doing all the right things, keeping the belly fat off. So he didn't have the zip he used to have. So this is not unusual to see at 51. So, and the numbers support, likely low T diagnosis is appropriate here. But he asks, could HCG be beneficial to increase or optimize the numbers? It could be to optimize the numbers, yes. But remember, we don't treat numbers. And what I'm getting at is what I've seen many times before is we'll raise the numbers, even in a 51-year-old. More often in 30-something-year-old, but the effect isn't there clinically. Sometimes initially patients will say, "Oh, I see the difference." In someone who might have, say, abused anabolics or I hate to say abused SSRIs, but maybe have been on SSRIs since they're 14 or whatever, and so the HPA axis hasn't developed properly, or for whatever reason their T is low, and at say 28 we get them on HCG. It might work for a couple of years even, and we'll see that in the numbers and we'll see it clinically, but then we'll only see it in the numbers, and clinically they come back and say, "Doc, I know I see the numbers, I just don't feel good anymore." In a 51-year-old, we're more likely than ever to see numbers change, although you get too old and even the numbers don't change. The testicles are done. They're saying, no, you can bug us all you want, we're not going to work. But sometimes you'll see the numbers come up a little bit, but the patient says, yeah, but I don't feel any different, Doc. So likely this is not a good way to go with replacement or for treatment to improve the symptoms of which he's complaining. But didn't he mention maintaining testicular function for, I thought he mentioned fertility. For fertility, absolutely, it can still help, because you don't need that much localized production of testosterone. In other words, in the testicles, intratesticular testosterone, to keep the Sertoli cells functioning, therefore to keep fertility. But in lieu of replacement therapy, I would say, if he's referring to testosterone replacement therapy, odds are against you. It's worth a try if you want at 51. I've never seen it work. The oldest I've seen it work is roughly 39, and one of the patients who actually, even after 39, tried to gut it out for a little bit longer before he finally succumbed to TRT. But, you could always try, because probability and possibility aren't the same, but highly unlikely. Can HCG be used safely long-term? Absolutely. We've seen it used long-term. It is a homologue of luteinizing hormone. So we call the receptor LHCG in the brain and elsewhere. So that hormone is presumably produced to some degree off TRT till the day we die, even if it's not that much and it's not helping to produce so much testosterone. So long-term safety has not been demonstrated to be an issue. How long would you be on HCG? I don't know. The guys to ask are the ones in academia like Dr. Lipschultz at Baylor, who've been doing this for many, many, many years. And I don't even know if they've aggregated this data. But again, there's no study to support that it would be an issue long term. Have you seen clinical benefit from daily DHEA only? Yes, I have. The adrenal glands will step up to the plate oftentimes when the testicles have faded, and you'll see elevated DHEA levels, and some of that can be converted into testosterone. It can also turn into other things that you might not necessarily want, like excess estrogen. And that's why I always say, look, if you're going to do this, if you want to fly from LA to San Francisco, why go via New York and risk, whatever comes with an indirect route? Yeah, whatever possibilities. But I have seen it work both naturally when patients come in and you'll see their DHEA off the charts because that's all they got left, and their adrenals are responding. But supplemental DHEA, just like with endogenously produced DHEA, runs the risk of conversion to a hormone that you don't want. So again, not my first choice, but it could work. And when you say clinical benefit, if we're talking about getting it to convert to testosterone, I just finished that thought, but there are other benefits to just having DHEA. You can see when you supplement with DHEA, sometimes you'll see, we call it backfilling of the corticosteroids, so you can see some decrease in inflammation. It's an arbiter of the immune system, arguably. You might see some increased energy, but again, more indirectly than directly, which I think is the point of Kai's question. So again, without having all the information needed, in general, at 51, my first recommendation would probably be to go directly to TRT, mainly because that's where you're most likely to see benefit without rolling the dice.
Awesome. Thanks, Doc. All right, Doc, what else we got?
Thank goodness for my iPhone.
Right? I know.
Question number 5 says, hi, I watch your videos with Dr. Rand, and I was hoping you could answer a question. I'm a 54-year-old man, and I'm considering a 10-week testosterone cycle of test and anthate.
A lot of older people this week.
I know, good.
Nice.
Well, this is obviously more appropriate. I shouldn't say it, but just more likely to be TRT candidates at that age than not. It is the first cycle I would ever be doing. My natural testosterone is 378. I assume that's nanograms per deciliter. My question: at my age, will my natural testosterone level return after the cycle? Answer: yes, but depending upon how long you're on the so-called cycle and at what age you come off. So if at 54 you decide to do this for 3 months, then more than likely you'll return to something very, very close to what you started at. In the same way, a female who's taking, for example, birth control pills will bounce back to her original levels of hormones as long as she didn't start taking birth control when she's 15, and as long as we're talking about that window of, say, I don't know, anywhere from, say, 26 to 35. Anyway, the point is your endogenous production will come back online. It may not be sufficient. It certainly isn't based upon at least this one assay, numbers-wise, saying that total testosterone was 378 nanograms per deciliter. But you should come back to something close to that if you just did this, like I say, for a short period, like 3 months. I would be using tamoxifen for a month for post-cycle therapy. Is tamoxifen better than Clomid in my situation? Again, guys, I'm giving general advice, not specific advice. In general, Clomid's not my favorite because of what I mentioned earlier. It's an isomer of two different substances, zuclomiphene and enclomiphene, and it looks like the zuclomiphene part of Clomid is what tends to give some individual side effects. Not all people get the side effects, but enclomiphene seems to do a better job. It seems to act like a SERM and a SARM, so my choice would be either tamoxifen or enclomiphene, but not Clomid, just to avoid the potential for side effects. And then he says, my concern is my age and whether this one cycle or two would force me to go on testosterone replacement therapy for life, or if I use a smaller amount, like 250 milligrams per week, and cycle properly, will this be okay? Kind of a loaded one, this last part, in that I guess the first question I'd ask is, why do you want to go back to where you started? It sounds like to me your natural testosterone is not doing what you would like it to do, like it did when you were, say, 25. So I'm not sure what the intention is to return to that level. And I mean,
it's going to suck.
Yeah. Well, and I can guess based upon my experience. I mean, people have this affinity for doing whatever they can naturally, and I won't wear out my expression yet again, but if they can stay natural, they would prefer that, and I understand that at a gut level. But if natural's not doing it for you, then why not, especially when it's such a night and day difference between natural and unnatural, why not go to the unnatural? And especially because based upon all the information we have, you're doing yourself a favor, not only with what I would call the hedonistic aspects of TRT, which is you feel better and you look better, but you will be medically, if you will, better. There's fewer incidents of coronary artery disease, type 2 diabetes, colon cancer, prostate cancer, osteoporosis when using TRT. So it's just a win all the way around. So, again, I think it's just a psychological issue that
I think people feel something they shouldn't be doing. So they want to do it because they probably hear of all the benefits, but like, I shouldn't be doing this. That's what
that goes back to our generation. Where it wasn't accepted like this, and guys were cheating when they were using it in sport or otherwise, and so the times have changed so much, and we're not ignorant.
It's better now than it was.
But it might be partly that artifact. Mm-hmm. But anyway, I get it. But still, ask the question. Mm-hmm. Why is that a concern? Now, for whatever your reasons, if I still want to go back to my natural, then a 3-month cycle, for whatever reasons you're doing it, shouldn't shut off your own production. If it were a 10-year or arguably even a 30-year cycle, at some point it might not be within 1 month like it would at 54 likely, and doing it for 3 months before your testosterone returns to what it would have been had you not done a cycle. Okay. At 30 years of doing this and coming off, it might take maybe even 9 months to return to a level of endogenous production of testosterone that you would achieve had you not done replacement therapy for 30 years, but were then still, by that time, 84. Am I making that clear? So you'd have don't forget, you're 84 now, 30 years later, so you'd have an 84-year-old's testosterone production. It would be whatever your natural production would be at 84, but like I say, it might take as much as, say, 9 months to get back to that level, because you're on it for so long, and you're an old geezer at that point, 84, certainly relative to 54. So, using a smaller amount, would that make a difference? No, it's not so much the dose you use, and I'm in no way backing what they call blasting and cruising, using really, I would almost say stupidly high dosages of androgens or anabolic steroids. But that's not the issue so much as the chronicity of use. It's how long you're on it and at what age you're doing it, starting and until, that affects your endogenous production and it bouncing back. I won't say or not, but how quickly it bounces back into what level. So it's not about, am I safer to use, say 200 a week instead of 250 a week? No. Do what's the most appropriate dose. It's all about the time that you're on it, not otherwise. And I think I got all the questions.
Yeah, it's good. Thanks, Doc. All right, last one for this time, Doc.
Last one for this week says, hey, Doc, thanks for the great work you are doing by putting true information out there. I know I speak for many when I say that. It is much appreciated. Well, Dave and I both say you're welcome.
Yes.
And it's a pleasure. My question is, aside from testosterone, which steroid would you say is the safest one to use as a stack for bodybuilding, and which would you say is the least safe? I know only a few are legally obtainable here in the U.S., but let's assume they were all legal.
He's watching the show.
He says, laugh out loud. Thanks so much in advance for answering my question. And he didn't leave us a name, but I didn't, for some reason I missed this one. I don't know if I can give you a complete list off the top of my head as to which are legal. I can tell you which ones make the most sense to consider, which I think is really what he's asking, and which are ridiculous. I believe, for example, it's easy to answer one part of this question. I believe halotestin, and I don't know the generic name for it off the top of my head, because why would I? I mean, I think it's on the formulary in the United States as legal. It's not contraband. But why would you want to use halotestin? Maybe there's a bodybuilding reason for it, that it does something super if someone's.
They say it really dries you out the last 2 weeks before a show. Really gets you hard, and I mean that's.
So just doing your homework right.
That's the word on the street. They say certain things should be taken just for cutting, especially the last few weeks. It just dries you out and really gives you that grainy condition. That's what that hardness. That's the word on the street in bodybuilding.
Well, from the research I've done, it's also very, very hard on the liver.
Yes.
And it's also very hard on the psyche for a lot of people. It comes. It's one of those things where normally I would say. When people talk about, he's on a roid rage. No, he's not. Typically, it's because he's not controlling his estrogen. And I should say he or she, because estrogen doesn't do either gender any favors when in excess. So that moodiness and irascibility is usually uncontrolled estrogen. But the exception, one exception is with halotestin. I think it comes with a signature, if you will, of more aggression, more moodiness. As does oftentimes Anadrol, which is also a legal.
Yes.
I've never prescribed Anadrol in my life. I can't think of a reason why I would need to. I know I've talked to other colleagues in this area, and I think I can. And I won't name a name. I don't know why, but maybe he wants to keep it more private, but. One physician has maybe prescribed it a half dozen times, according to him.
Is it for anemia, or what is it for?
Well, it's for I believe pernicious anemia is one of the indications. But for really, really difficult cases of cachexia or hard gainers, where you just can't put on weight. Well, I've never run across that. I mean, usually it's something where diet and exercise, if those fail along with TRT, then you can use something which is much more gentler, meaning with fewer side effects. And that's the problem with the Anadrol, real quick, is it doesn't convert to estrogen, but it converts to a substance that acts like estrogen, it seems like, and have those same side effects, moodiness, irascibility. So for some people anyway, it can make you feel horrible. So why would you go there? Mm-hmm. If you can use something anabolic like a legal steroid, for example, nandrolone, lifesaver, literally lifesaver for someone with a wasting disorder like HIV. Well, not the same, but oxandrolone, which used to go as Anavar. Mm-hmm. Another very safe anabolic steroid that you don't worry about these symptoms. First of all, it's a dihydrotestosterone derivative, so it won't convert to estrogen, period. So you don't have that particular side effect. It's an oral though, so if you're definitely trying to put on weight on someone, nandrolone might be a better choice. Nandrolone, technically, a little bit of it can convert down the line to some estrogens, but nothing really material. So again, another very safe one, and it's injectable, so you don't have to deal with that first pass on the liver. So least safe, I would say, halotestin for just its effect on the body. Halotestin for its effect on the mind, Anadrol for its effect on the mind, possibly. Some people don't react this way. The problem is when I say something like that, because halotestin I don't see it prescribed, I don't see it in the marketplace, so to speak, in the business. I don't have people coming in and saying, yeah, my other physician has me on halotestin, my other physician has me on Anadrol. Do we know that patient who says, I'm taking halotestin, I don't have any side effects, is truly taking halotestin? Because it might be bootleg is what I'm getting, mm-hmm. Something obtained, in the black market. Because again, I don't know any physicians who prescribe halotestin, and very few who even prescribe Anadrol.
Why does it exist in halotestin?
these are things that I have no answers for because I'd have to go back and do some research, and it might be an interesting dive to see when was it legalized, when was it made,
for what purpose,
available by prescription, and why was it left there?
Mm-hmm.
There's all kinds of stories. I heard GHRP 2 and 6 were taken off the market not last May 2020 but 2019 because of sort of a random check of a specific pharmacy looking at something else, other requirements of it's part of regulation, and look, we saw this. Oh well, you guys shouldn't be doing that. And GHRP 2 and 6, I'm making the story way too simple.
Yeah,
but it was taken off the market. Why that hasn't happened with halotestin? Because there are other much better drugs. I don't know, but it'd probably be an interesting dive in to see what happened. But the more safe in general are injectable, and that's kind of I have to say that, but safety, whether you take it orally or injectable, contrary to what we used to believe, when we were comparing an oral like methylated testosterone, one of the original oral dosages of testosterone was much different. It was methylated so that it would make it hard for the body to break down, therefore keep it around longer. But because it made it hard for the liver, it was considered not good for you. We have an oral testosterone now, an undecanoate, which I think requires 3 or 4 times a day dosing. So it's not on my list of preferred things just because of, I think, compliance would be an issue, patient compliance or preference. But we don't worry about that anymore in terms of its effect on the liver, males or females, meaning males even a higher dose, because we realize it's not like methylated test. So that's kind of I'll call it an artifact of yesteryear. There's not that big a difference where you'd have to worry about it. You might have just as much of an effect or more by taking a high dose of Tylenol than you would of an oral like oxandrolone, an anabolic steroid. So when I say safer, it's technically safer just because you miss that first pass on the liver when you don't ingest it and you just inject it. Mm-hmm. The other legally obtainable in the U.S. Off the top of my head that I would ever deal with would be stanozolol, which used to go by the brand name Winstrol.
Yeah. People prescribe that?
That one's unique in that one of the few occasions I ever considered that was for someone who had kidney failure as well as cachexia and was an older gentleman who didn't have the muscle mass, unfortunately, to even get up off the potty without assistance. Very proud man, and his whole family. It's a long story, but it's designed for angioedema, or one of the indications, I should say, is for angioedema. It's very similar. It's a dihydrotestosterone derivative, so it's very similar to oxandrolone, but it has this extra feature of what bodybuilders would call drying you out.
Yeah.
So it seemed like a good try because it would give two things. It would help get rid of the excess water that he was accumulating because he had chronic kidney failure and some heart issues, but also get some meat on his bones again and some strength back.
Did it work?
Never. I think I actually got to write the prescription. It was never filled because unfortunately he passed away. But it was just the idea of here you got something with an extra feature for angioedema. Yes. That would be a consideration. But for someone else who's 40 years old, 50 years old, we tend to dry out as we get older. I think we're born about 70% water, and if we make it to life expectancy today for males about 79, we're about 50% water at that point. We desiccate. So why do we want to dry out even more and risk tendon damage? So it's I know bodybuilders look at it to help dry out instead of using diuretics, which to me that's a whole other story. I think that's nuts. Anyway, so I mentioned oxandrolone, stanozolol, nandrolone, which used to be called decadurabolin. I mentioned anadrol, which again I haven't had occasion to write for. Any other?
What about Primo? Is that legal or not?
Primo would be a great one. I don't know why we don't have that one legal here in the United States because it's a dihydrotestosterone derivative like the other two, oxandrolone and stanozolol I mentioned. It's injectable though. And I've even mentioned this to the pharmacy, but whatever the regulations are, I don't remember what the rationale behind not being approved for development and use in the United States. Why don't we do a suspension of oxandrolone, or if it's possible, something that's an oil base, like Primobolan, because again, it has the feature of being able to be injected, which again allows that first pass of the liver to be avoided. But Primobolan would work similarly to Anavar. It's just I don't know why it's not available.
I thought it was legal for some reason with prescription. Weird. Okay.
Not here in the United States, to my knowledge.
Okay.
And there are probably more that are legal. I just don't know them because I don't have occasion to use them. But the rest of them, so ones I know are considered contraband here would be things like Dianabol, Equipoise, well, except for veterinary use.
Mm-hmm.
What's the derivative of, gee whiz, it starts with an M, the guys...
yes.
Anyway, they're Masteron, and the other derivative that's even lighter than Masteron that they use sometimes. Those are all contraband in this country.
Yeah.
And it doesn't mean that they're necessarily dangerous.
Mm-hmm.
It just means they haven't been studied and approved by the FDA here. So, I don't want to give you a thumbs up or thumbs down one way or the other because we don't have the studies here, and here we are in the U.S. But, you can look at the structure, and I think most of the risk you take if something is not approved here is because if you are getting it here, more than likely it's been made in somebody's, laboratory.
So who knows what's in it?
And it's not, well, aside from the legal aspects, why do you want to get into trouble legally? But if you're taking that risk, you're also taking possibly a medical risk because it's not done in a proper environment in a pharmacy. But I'm trying to think if there's any others. So one of the ones that's popular these days is Trenbolone.
Yeah, yes.
That's not legal here. No. And I don't think it ever was. It used to be way back when
Parabolan in France. Yeah, 76
and it was a different, it wasn't an acetate or an enanthate. It was a different form, starts with an H, I forget. Sorry, I'm not having a good day with my words. But that one also came with a lot of side effects. But
really?
Typically with Trenbolone, you have pretty serious night sweats.
Yes.
It has a very strong affinity for the androgen receptor. I won't say it has side effects like halotestin, but it can come with some aggressive tendencies. Yes. Again, everyone's different, but so I'm sort of generalizing, definitely generalizing, not sort of.
Yeah.
But maybe you have some other names that you can throw out there that
No, that's pretty much all
what's out there.
Yeah.
I mean, so most of them aren't considered legal and are considered contraband, unfortunately. Mm-hmm. And I say that just because it'd be great if we do some studies to make sure that we can vouch for safety of some of these versus not.
Yeah.
But I'm sure there's a lot of things on the FDA's mind right now.
Yeah, exactly. Yeah, exactly. All right, good question. Thanks, Doc.
Thank you.